So I will be talking in brief about how OCT can come to our aid in resolving some of the queries or some of the conundrums that posterior uveitis can pose in front of us. Now, it's impossible to cover everything in the next 5 or 7 minutes, but let me just tell how OCT actually can be used in a lot of these uveitis cases to not only identify the disease, but also to understand, like what we have seen in some of the previous talks. Dr. Vaishali brilliantly showed some of the ways where OCT comes to our help in mutes and in serpiginous APMPP. So multiple conditions and how activity and complications can be picked up by imaging in a lot of these cases. Now, when we start looking at our OCT, multiple level or planes of interpretation of those images can help us in essentially not only realizing what's happening, but in some cases even pinpointing the underlying etiology. And let me just show you how some of these will evolve in some of the next cases. So looking at OCT, first of all, just looking at a vitreous or a vitreoretinal interface in itself can help us in understanding, or at least initially differentiating between the lesion that we are seeing. Is it inflammatory or uveitic or a non-uveitic condition? This actually is a case which I'll show later on, was initially seen as one of our by our oncology colleagues and posted for a biopsy. But a look at the OCT in itself shows these multiple cells, something which is not going to be seen that commonly in an underlying neoplasia, but is rather an indicator of the fact that you are dealing with an ocular inflammation in one form or the other. Apart from that, hyaloid getting adherent, another clue to the fact that there is intense inflammation going on. There is fibrin which is leading to this hyaloid getting adherent over here. Or the fact that this is something which has been described as a rain cloud sign, which in itself is very specific of an endogenous endophthalmitis, more commonly seen with the candida as an underlying etiology. So just looking at an OCT in itself can start giving us initial clues about what we are dealing with, looking at the vitreous and the interface. Apart from that, OCT also gives us an opportunity to look at the level of involvement of what's happening. So full thickness retinitis, hyaloid getting adherent over here, a bit of a coronal involvement in itself makes our diagnosis pretty easy that you are possibly dealing with a toxoplasma retinochoroiditis. Again, the same case, and we will see this case subsequently, again shows us that essentially there is also a coronal involvement happening. You can see this elevation over here, which shows that there is some pathology at the level of the choroid, apart from what's also happening in the subretinal space. And you see this fibrin getting accumulated over here in the subretinal space. So looking at the level of choroid initially, apart from looking at what's happening at the subretinal space, putting all of those clues together again becomes a very important way of interpreting our OCT findings. And then full thickness retinal involvement. So like we said, when you look at the thickness or the involvement of the layers of retina, again having mealy lesions with a full thickness retinal involvement, again a very important clinical clue. And then lastly, going on to the outer retina and seeing what's happening at the level of the photoreceptors and at the level of the RP. So you put all of these points together, and in a lot of these cases, the puzzle in itself gets solved. And let me now show you a few examples where we put all of these clues together to arrive at what we are dealing with. So this was a 27-year-old patient who came to our clinic a month back with a decreased vision in the right eye. The right had a vision of 20/100, and the left eye was essentially normal. And if you look carefully, what you see over here is a very faint, subtle lesion which can be appreciated at the posterior pole. And autofluorescence now reveals few areas of hyperautofluorescence when you look carefully. And the moment you see an OCT, the diagnosis nearly comes blaring in front of you. So this is what's happening in the right eye. You see this extensive RP nodularity, some amount of photoreceptor damage. And the moment you see this sort of an image, one of the most important clinical differentials that comes to your mind is ocular syphilis. We got this patient tested. He came positive for treponemal as well as non-treponemal test. Was a patient of ocular syphilis, started on doxycycline because he refused to take IV penicillin, and patient subsequently improved to 20/20 within a span of 2 weeks. So we already have literature which shows spectral domain OCT findings in syphilitic posterior placoid chororetinitis, where you see these changes at the level of photoreceptor, and these are classic clinical patterns which can be seen on OCT. So when you see a patient with RP nodularity, amount of some placoid changes at the level of photoreceptor level over here, some changes in autofluorescence, think of ocular syphilis as one of your differentials. From placoid retinitis to full thickness miliary lesions, again this was a sign that we had described earlier. So when you see these miliary lesions, get an OCT, and if you see a full thickness retinitis, that again is a clue to ocular syphilis. And lot of times these miliary lesions will happen in eyes which have been earlier treated with systemic steroids in the absence of an appropriate antimicrobial agent. So this is something which is very common in eyes which have been wrongly treated. I'll just go through this. So this was a patient who was initially seen over here with these miliary lesions, was actually given Ozudex earlier. And when we saw these lesions, we thought this is syphilis because of those miliary lesions, and that's what it was. Treated with penicillin, most of the lesions went away. The another clinical clue which can help us in arriving at a etiological diagnosis is hyaloid getting adherent. So posterior hyaloid adhesions to the retinitis lesion is another common biomarker which we described, which can be used to differentiate between viral or toxoplasma retinochoroiditis. So this is a patient who was seropositive, came to our clinics, was initially diagnosed as CMV retinitis, was given intravitreal ganciclovir. But when we saw the patient, what we saw was hyaloid getting adherent. And because of that sign, we started this patient on Bactrim DS and look at how the lesion starts responding. Within a span of 2 weeks, you see a resolution of a lot of these lesions. So hyaloid getting adherent can be another important clue to differentiate between etiologies. How much time do I have?
Your time is up.
1 more minute if I can. So in terms of diagnostic dilemmas, and just last of my case, I will not dwell much on OCT angiography because I honestly don't use it that much. But again, OCT gives us an idea of how to differentiate or look at different planes. So this was a case diagnosed as an amelanotic melanoma and was about to be posted for a biopsy. But my oncology friend asked me if you can just have a look at this case. And this is what you see. You see the amount of cells in the vitreous, you see the subretinal fibrin. And then we said this is probably not neoplasia but an ocular inflammation. His scans came positive for a lesions in the CECT in the chest. MON2 was positive, diagnosed as a case of TB granuloma. Started on ATT, and within a span of 2 weeks you see a resolution of lesions. So I'll now stop. But what I'll say is that OCT essentially helps us in identifying what you're dealing with, can be a very important clue in not just understanding the activity, but also in unraveling the etiology of the entity that you are dealing with. Thank you so much.